What wonderful to have you all with us for this very important webinar. This came out of research that we asked the Francophone community to help us with, and Simone certainly rose up to the challenge. So this is a piece of work that has been done under our Impact Awards at SPORE OSU, which is the Ontario Sport Support Unit for the Strategy for Patient-Oriented Research. This afternoon, you're going to find it interesting to hear how a difficult issue that we've been trying to tackle in the Ministry of Health has been demonstrated to be having great potential for implementation. So that's what we want to hear from all of our participants. I want to thank Karen, Simone, Pamela, Natalie, and Kiran. You'll find as they present the work to be most illuminating. So we also hope to have sufficient time for discussion where we can ask people questions and try to formulate in your own context how social prescribing, patient navigation might work. So thank you. And Simone, I invite you to start.
Thank you. Thank you so much for this invitation. I'm going to share my screen. Okay, so I hope everybody can see the full screen. Welcome to Social Prescribing, the value of a holistic patient navigation support on equity. I would like to begin with land acknowledgement. We pay respect to the Algonquin people who are the traditional guardians of this land. We acknowledge their long-standing relationship with this territory, which remains unceded. We pay respect to all Indigenous people in this region from all nations across Canada who call Ottawa home. We acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. And I'm especially grateful for the lessons I am getting from those leaders. I'd like to thank my team. So we have with us, so this is, I'm sure there's people that should be on the slides that are not. We had a group of researchers and we had a group of stakeholders, and I think that's partly what made this a success, who participated in the development and the evaluation of this program. So this program is called Access to Resources in the Community. So it's ARC. We have today with us Karen James, who was part of the stakeholder group. Karen's a patient partner with just amazing insight that has really contributed immensely to the success of this program. We have Kiran Saluja, who is a senior research associate, Nathalie Bourgeon, who was the navigator in Sudbury, and Pam Hillier, who is our new partner that we're looking towards for the scale up of this program. We'd like to begin with a survey to help us understand who the audience is. So John's going to put up a survey, and we'll take a minute to answer the question. So it'll give us, an idea of, where people are from. So it's not surprising. Most of us are from Ontario. This is an Ontario initiative. It'd be great to get other provinces. Oh, here's Quebec. Wonderful. Happy to see colleagues from Quebec. Shall we go to the second question, John?
I believe the second question is already displayed. So folks can go down to look.
Oh, that's
Yeah.
interesting because I don't see it. I don't see the second question, but maybe other people do. I'm still seeing the province.
Same here. I only see the province.
Same.
Okay.
Okay,
So,
some people are able to because they've been answered. If you
that's interesting.
put your cursor on the survey and maybe scroll down, that might help. If not, then we should probably just proceed.
Oh, no, scroll down. That's what we needed to do. Thank you. Okay. So we've got some research trainees, some researchers, some healthcare providers. Yeah, that's great. Patient partners, and interested members of the public. Oh, and industry partners as well. And I see that the majority have some experience with social prescribing, so I'm not going to make any assumptions. I'm going to speak to the audience in general. I can see some comments in the chat. I'm not going to go get these, but if somebody can look at these to make sure that nobody is left out. I'm going to end the poll. Okay. Okay. Cette session est livrée. Are we still seeing the poll, guys? Because I'm still seeing the poll. I'm trying to get it out of the way. Okay.
I've stopped it.
OK, thank you. Cette session est livrée en anglais, mais on vous encourage à demander vos questions ou donner vos commentaires en français. On pourra répondre aux questions à la fin de la présentation. So the questions will be answered at the end of the presentation, but I encourage you to put your questions or comments or thoughts in the chat box for now so that we'll have them at the end and we'll be prepared to answer them. Okay. So I'm going to begin by explaining what social prescribing is. And first, I'll tell you that the development was initially funded by CIHR. It was very well received, that model. OSU very generously funded us to compare this navigation model to the Ontario 211 existing telephone and web navigation support. In that case, patients have to call in. So the two are a little different. So we entered a partnership with the region, and they essentially told us what features that navigation program should have. And the objective was to improve equitable access to community resources that are needed. So let me tell you what social prescribing is. The first point is in primary care, and we started in primary care because this is the one point in the healthcare system where most people go. Most people are attached to a primary care provider. They can identify health and social needs for their patients and encourage them to engage in this. They do it to some extent. Oh, you should consider a smoking cessation, or have you considered more exercise? But they don't have the tools to go beyond that. So in this program, in a social prescribing program, they refer the patient to the program, give them a copy of the referral, send a copy of the referral to the navigator. In this case, the navigator applies a very holistic approach to support the patient access the resources that they need. So their goal is to find the right resources in that community sector, help them overcome whatever barriers they may be. It may be financial barriers, it may be time barriers, it may be caregiving needs that they need to have somebody help them with. And they provide three kinds of support. One we call instrumental, which is essentially, what can I do for you? I can fill out the form, I can make the phone call, I can arrange for transportation. The other one is information. I can tell you what the resource is. I can tell you, their hour, who their target clientele is, what the benefits are. And really importantly is the emotional support. That relationship with the patient can last weeks until the navigator has met the patient's needs. At the end of that, the information, a summary information, returns back to the primary care provider. What's important, why ARC is different from other types of navigation programs? It's a single point of entry in primary care. So the primary care provider has a patient, regardless of the need, regardless of their cultural background, they can make that referral. It's a bilingual lay navigator, so we're not talking about clinical support. And it offers a holistic service. So it takes the patient as an entity entirely, understands their situation. Okay. So this program was successful, and we'll show you that. One of the reasons why it was successful is how that partnership helped us establish the program. And I'm going to ask Kiran if she can tell us. Kiran was our patient partner for 5 years. If she can tell us a little bit about her experience in the stakeholder committee. Kiran, make sure you're not muted, because we were all muted at the beginning.
Yeah, thank you for that. So I came into the project as a patient partner. And first of all, just understanding how to be a patient partner was part of the experience for me. So I had 3 days of patient engagement training in Toronto, which was amazing because I got to understand how that process actually worked. I had some opportunities to attend some primary care research conferences, which taught me a little bit more about the whole process. And then when I actually arrived to be part of the partnership, one of the things I found is I was really treated as an equal partner at the table. And so I never felt like I was a patient partner or someone less than the other people at the table. So I was given an equal sort of voice there. The way the meetings were structured, I had an equal say at the table. And the way that they were structured was there was a small group that you were put into, and there was a person of every representation there. So if you had people that were researcher, or a person that was a clinician, or a person that was a decision maker, and then myself as a patient partner, beautifully done. And so you were all working together in that small group. And then in the larger groups, when we were making decisions, we all had a say as part of that. So my decision or my say was measured in there as well. And then the consensus was made based on that. The other thing that I would say was the values, the consideration for people. I was coming from a job, so I was offered an opportunity to get transportation there. And the nice thing I often said was there was a dinner provided. This was in an evening. And so they had meal that they offered you. I couldn't say how valuable that was, considering I was coming from work. So just a lot of really being well treated like an equal, and really being part of the process.
Yeah. This had started about 10 years ago. And at the time, there was no such thing as patient partner payment in our budget. So we weren't, Kiran did this out of the goodness of their heart. She's a very strong advocate for patients and what their need. I want to show you what our patient experience looks like. So we compared that ARC holistic approach to the Ontario 211. So essentially, when the doctor made a referral, we randomly attributed them to ARC, which I've described, or we said to them, there's this provincial navigation program. All you have to do is dial 211, and a navigator will help you find the resource that you need. And primarily the type of services that the 211 offered were informational, which was great. We had nothing before. But you can see that the patient experience is very much in favor of the ARC arm. So the ARC is in red, the 211 is in blue. Across the board, whether we're looking at if the patient felt that they were helped, if they felt that the communication was good, their overall experience, it was really high in the ARC arm. Kiran, can you give us some insights about, like, so what do you think we did right? We did something right. And what do you think the recommendations from the stakeholders were that helped us get this right?
I think a lot of it was the importance of having that personal connection with the people. I think there's nothing better than that. I think it makes people very comfortable and allows them to feel really heard, and it offers that holistic experience. So this active listening to the individual, their ability to then to prioritize their issues. There's just so much about two people actually being able to see each other and sort of to talk to each other that changes the game for people and allows them to feel much better heard and feel much more comfortable in addressing their needs, and feeling like their needs are being heard and addressed just makes a big difference.
Yeah, you know, when we started this program, we didn't have the words social prescribing. We independently developed a social prescribing model, which existed in the UK, but was not in Canada. So we, and at the same time, the Alliance were the first to bring it to Canada. And now studies have shown that the patient-centered approach, the holistic approach, the communication is really important. So let me show you a little bit the training. So we developed, there was no such thing as training for the navigator. We developed the navigator training. We had an amazing educator who did that based on the competencies we needed to see. This was a 12-week face-to-face online. It was a multimodal training. And I'm just going to highlight a few things that I think are, you know, we really want to remember. Establishing a trusting relationships, understanding and respecting differences and social disparities, communication. The communication, active listening, motivational interviewing were really key to forming that bond. And I can't tell you how often patients commented on that, on their relationship with the navigator. So let me turn to the navigator. One thing I didn't mention at the beginning is I'm going to present the results in terms of the quintuple aim. Those of you who don't know the quintuple aim, don't worry about it. I'll list each one as we come. So the first thing I actually mentioned the patient experience. So that's one of the aim. We want to have good patient experience. The other one is provider experience. And here we have two providers. We have the family physician who's making the referral, and it's their patients and what's their experience. And we also have the navigation service provider. So I'm going to ask Nathalie to tell us a little bit about her experience.
Okay, so yeah, my name is Natalie, and I was the patient navigator for the study in the Sudbury region. There was also another navigator for the Ottawa region. So there were 5 main themes that were identified, and that paint a sequential picture of the journey of leading individuals from primary care to health and social community resources. So the first one that was identified is gaining and building trust. So as Simone was mentioning, building that therapeutic relationship was important in order for patients to be able to trust you and to feel comfortable enough talking to you about their concerns. Developing empathy was important. That's really just putting yourself in the patient's shoes and trying to see things from their perspective. Experiencing hope and optimism. It was encouraging when you would see patients get excited about accessing certain community resources and you thought it would really be beneficial for them. Feeling helplessness. So sometimes, unfortunately, there are barriers to accessing community resources. So those can be things like finances, not meeting eligibility criteria, or other things. And sometimes there are also feelings of helplessness where the client's needs went beyond the scope of what the patient navigator could provide. So for example, that could be more medical support that was required, or they would have required more like counseling type of support. and then celebrating gains and successes. So it was really great seeing patients accessing community resources and deriving benefit from doing so.
Mm. You know, the patients were complex, so and that's important. So I'm going to show a little bit of the profile of the patient. So 72% did not have a university degree. 78%, the 3/4, made less than 75,000 as a household income. That's low. And while only 16% were 65 and older, 60% were not working or in school. So this was a complex patient population. One of the things I neglected to say at the very beginning is that one of the objectives of the study was not just to compare ARC and 211, but we wanted to know how the francophones, how well the francophones would be served with the ARC model and the 211 model. And instead of developing a separate model for the francophone, and sometimes you need to develop an approach to a specific population, but in this case we felt, you know, we just need to be able to adapt what we do to use the active offer. If you don't know what that is, this is, you know, when you go to the airport and they say hello, bonjour, that's active offer. They're telling you, speak to me in French or English. I'm bilingual and I'll serve you in the language that you want. So that's that was one of our priorities, was to understand, are we going to get benefit? Is it going to be, are we going to improve equity? And what about the francophones? So I want to point out that about 1/3 of our population was francophones. So that's the profile, which shows social complexity. The other thing is, what did they come to us with? What type of needs did they come to us? Because remember, the primary care provider identifies the needs in primary care. So it's important. These are not clinical medical needs, they're health and social needs. And so these are it. So some are more obviously directly health related. Mental health, 60% of the referrals. It was often not alone. There was, I think, on average, 3 needs per patient. So mental health was by far the most common one. And then we had a lot of the healthy habits, healthy living behaviors. So physical activity, healthy diets, and so on. And we had the social determinants of health. So these were important. That's a very important part of what makes an individual healthy. So having shown you what they came with us with, here's, I'm going to show you what the navigator did, but I just want to remind you that essentially the role of the navigator was here. So they get them from primary care. We looked at that before. They link them to the community sector, but when they're doing their navigation, again, their type of support is provide information, help them overcome specific barriers, and provide emotional support. So here's the type of support that the navigators identified. So Nathalie, can you put that into context for us? What does that mean?
Yeah, so there were 3 main types of support that was provided to patients. So the first type is informational support. So an example of this would be communicating with community resources to obtain more information, because sometimes like the information on the website wasn't always up to date. So if you called and spoke with someone, they could give you more accurate information. Mm-hmm. That also included doing research on the different community resources available locally. And looking at different things like eligibility criteria, types of services that are offered, and then also providing resource material to patients. So for example, providing them with phone numbers to call, websites, and general information about the community resource so that they could read up on it to see if it would be something that they'd be interested in. Mm-hmm. For emotional, that would mean providing emotional support and active listening. And as Simone mentioned, like emotional support is very important because it helps to empower the patients and give them more confidence, which can then impact their ability to engage with services. Another type of emotional support was providing advocacy as needed. And there were also some patients where I accompanied them the first time they attended a community resource because they were a little bit nervous about going by themselves the first time. So in terms of instrumental support, this was more helping them to do things like making phone calls or completing forms, because doing those things can be daunting for certain people. So more specific examples would be, like I mentioned, calling and making appointments with the resource, helping patients complete forms, organizing translation, helping to arrange transportation, and also helping to find funding when needed.
Okay, thanks. And I know you've got some qualitative some quotes that you want to share with us. So maybe I'll put these up and you can speak to these.
Yeah, so the first quote describes how the patient wasn't aware of the community resources that were available locally. So an example that I have is that I had a patient who was a stay-at-home mom, and she had 2 young children. And she was interested in bringing her children to groups or activities where she could get out of the house and meet other people with children. So I provided her with information on different programs that were available locally that she wasn't aware of. And then she was able to access a free group, like a program that was close to where she lived. And she was very happy about that because she was able to meet other moms who had children like that were around the same age as her children. So she was very happy with that. The second quote describes a patient who was dealing with some mental health struggles, and they really benefited from the emotional support that was provided. So one patient that I had was an older adult who had issues with her mobility and could not get out of the house too often because of these issues. And she was going through a tough time, which was impacting her ability to access community resources. And so I would call her every now and then to check in just to see how she was doing. And she had communicated to me how she was very lonely, and also how she really appreciated that there was someone that she could talk to about these things. And that could also help point her in the right direction in terms of what type of community resource that would potentially be of benefit to her. And the third quote describes instrumental support. So one example of this is that I had a patient that was wanting to apply for social assistance. However, he was illiterate and he wasn't able to complete the forms on his own. So I met with him and his partner in person, and I helped to fill out the forms based on the information that they gave me. And then I forwarded the section that was to be filled out by a doctor to the client's primary care provider. And then the patient was then able to mail out all the documentation, and he was very appreciative of the help that he received because he wouldn't have been able to complete that on his own.
Yeah, it's interesting how even a small thing like that is a barrier for many of us. So that's really important. Thank you. So we covered the patient experience. We covered one provider experience. Let's take a look at the other provider experience, because if the primary care provider isn't happy with the process or the services, this program can't work. So I'm going to ask Kiran to tell us give us the primary care provider's perspective for ARC.
Okay. Yes. So yes, our providers, they had positive experience with ARC. Providers, they told us that ARC, it increased their awareness about the community resources that were available to their patients. Like, for instance, one of the providers pointed out that even just the knowledge of what's available out there in the community, it was important for them. And from ARC, they learned about various services which they had not known earlier. And having the support from ARC Navigator, it actually encouraged them to make referrals, because now when they make these referrals, they have someone who can help their patients. And this was especially true for the non-interprofessional practices. They felt that they now have something to offer to their patients with the help of the Navigator. We can see that in the quote here. And most importantly, the vast majority of the providers, they felt that participating in a social prescribing program, it did not interfere with their practice functions. So this was very important for us to know.
Thank you. So we looked at the provider experience, patient experience. It's really quite positive. Did we help the patients? One of the mandate or the role of the Navigator was to help the patient, not just link them to the community resources, but help them build self-efficacy. So how did we do in that sense?
So yeah, we looked at whether the two type of navigation services, they had any impact on patients' abilities to access a resource, whether their ability to pay for healthcare needs or their ability to seek information and services had changed, or whether their ability to perceive the need for care has changed, and how well they engaged with their healthcare. So we asked them to rate their abilities at the beginning of the program and then 3 months later. To begin with, what we observed was at baseline, the scores looked quite similar between the two arms. But post-intervention, overall, there was a trend towards improved abilities in both the arms. So first, we looked at the change in abilities from pre to post, each arm separately. And then we looked at the difference between the two arms in terms of improvement. And this we call as difference in difference. So what we found was the improvement was higher in ARC arm for all the abilities compared to 211, except for the ability to pay, which we see is quite similar in both the arms. And ARC patients, they were more likely to engage with their healthcare compared to 211. And this difference was statistically significant.
Yeah.
So when I say statistically significant, I mean to say that the difference was unlikely due to chance alone. And
Right.
remember, yeah, and as you mentioned, Simone, that the key role of the navigator was to support the patients to improve their self-efficacy and empower them. So our results do point towards that, because ARC was superior to 211 in improving patients' self-efficacy.
Yeah. I mean, these results around the seek and perceive, they're not statistically significant. They suggest the trend. We can't say for sure, but certainly it's a good indication that they are benefiting. And this is not much of a surprise, because ARC was a resource intensive intervention, so we expect this. So we help them in their self-efficacy. And what about sort of our main outcome, which was was ARC better at linking patients to the resources that they needed versus the 211 service?
Yeah, so the answer is yes. The patients who were assigned to ARC arm, they had better access. In fact, we observed 40% benefit for ARC arm. So 50% of the patients who were assigned in ARC arm, as we can see, they accessed at least one resource compared to only 36% of patients in the 211 arm. And these differences between the arms here, they were statistically significant.
So that means there's a very low chance that these differences are due to chance. This is, real differences. And this is self-reported by the patient. Did you access a resource for whatever their first need was? Did you access the resource for the second need? So we looked at all the needs that had been identified. Still, a good percentage, 50%, did not access a resource. And as Nathalie was saying, there are some things that the navigator cannot help overcome. And I'm sure you can think of the most important one, and that's the readiness for change, or the motivation. And as much as the motivational interviewing is helpful, we can't do the changes, for them. They need to be ready. So when they're ready, they will do it. Okay, so there's a benefit, not huge. So this is a relative benefit to 40%. Did we improve equity?
I can say that our social prescribing program, it provided an advantage to socially complex patients. So we looked at the association between some of the patient factors and access. So here are all these numbers. These are odds ratio and confidence interval in the brackets. Don't worry too much about these numbers. Odds ratio is, like, simply put, it's the likelihood of an event taking place. So if we see that the number is more than 1, it shows that the event is more likely to occur. And if it's less than 1, the event is less likely to occur. And if our results were statistically significant, that's not just by chance. We've shown them in bold and asterisk. So here what we see is those who did not have a university degree, for example, they were less likely to access a resource compared to those who had a university degree. Their odds, as we see, its odds of access is lower than 1. In contrast, patients who had around 2 to 6 needs, they were more likely to access compared to those who had only 1 need. And similarly, if patients were there who spoke French at home, that is, they were francophones, they were more likely to have access to resource compared to those who did not speak French. And next, we wanted to understand, like, what's driving this? Is there a difference between the 2 arms? So we stratified this analysis by arm, and it was interesting to note that patients, those who had multiple needs, they were more likely to access if they were in ARC arm. We see this odds ratio of 4.9 here. And also another important point was patients who had more needs, they had greater odds of completing the study if they were in ARC arm. So it could be because complex patients, they received tailored support from ARC Navigator, and that might have motivated them to complete the study. Coming back to access, so patients without a university degree, they were less likely to access, and their odds of access was even lower if they happened to be in the 211 arm. For francophones, they sort of had same benefit in both the arms, ARC and 211, though it reached statistical significance only for 211 arm here. Okay. But the estimate seems quite similar.
Okay, thank you. Well, what else do we know about the francophones in this study? How did the navigation services perform in that population?
Yeah, so francophones, as we define them, as those who speak French at home. So patients' experience was pretty much similar for both francophones and non-francophones. And it was always better in ARC arm, as we can see. And in terms of access, so in terms of access was higher in ARC arm compared to 211 arm in francophones also. So overall, they had better access than non-francophones. Like we can see, access was 63% here in ARC arm. And if we remember from our previous slide, it was 50% for the overall sample that we've just seen earlier. And our study also demonstrated the benefit of ARC approach in achieving better language concordance for francophones. So by language concordance, I mean patients who want services in French, they receive French services in French. And this was particularly important because we know that language discordance, it is more likely to have errors in care delivery, lower satisfaction level among the patients, or even poor experience and health outcomes for the patients. So it is really important that the services are in the language that the patients prefer. So for language concordance, it was higher in ARC arm. We were at 91% compared to 211 arm, which was 31%. And this difference was also statistically significant.
Okay, thank you. So what you've shown us is, in general, ARC performs considerably better. It's better at closing inequities, but we alluded already to the fact that it is resource intensive. So what about the economic impact? What do we know about the scalability of this?
So we did not conduct an economic evaluation per se, but I can say that ARC navigation support, it was resource intensive, as you've just said, Simone. And the navigator spent roughly around 2 hours per patient just in communication. I mean, this includes interactions with patients and caregivers or their care providers and service organizations. And in addition, the navigator also had to spend some time on searching for appropriate resources or documentation, administrative tasks, and other tasks. So yes, ARC services were costly, but it did have a positive impact. Like, it benefited the patients. The patients were satisfied. Providers appreciated our program, and the providers wanted such kind of a program to continue. So.
Okay. The second aspect of an economic lens.
Yeah, so we also looked at the healthcare utilization data. So we used the Ministry of Health billing data, and we linked it to our patients' records through OHIP, and we assessed healthcare utilization across the 2 arms over the 2 years after their enrollment in the study. So we first looked at the number of all outpatient visits and the number of visits to primary care. So the numbers that you see here are again difference in difference. And if it is less than 0, it means that ARC had lower number of visits and compared to 211. And if it is more than 0, then probably ARC patients had a higher number of visits. So what we see here is in both the years, outpatient visits and primary care visits, they were lower in ARC compared to 211, but it was not statistically significant. But we do see a trend here towards reduced visits for both outpatient and primary care visits, which is encouraging. And this benefit seems to be greater in the second year, as we can see. And if we want to look at the acute care setting, in the first year, ER visit estimate was actually greater than 1, which implies that our patients, they were more likely to have ER episodes. But again, this is not significant. And it did drop in the second year, as we can see. And the odds of having 1 or more hospitalization, it was less in ARC arm compared to 211 in both the years. And here also the benefit we see it increased in the second year. So overall, what we see here, there's a trend for low healthcare utilization in the ARC arm, which is good, but we did not have enough sample size, so we cannot say that with a lot of confidence.
I see. Thank you. So our next steps were to partner with our wonderful community connection partners and see whether we can gain efficiencies by merging our two approaches. So now I'm going to ask Pam to tell us about the model that we are developing together, and maybe a little bit of the historics, and also just that make sure we're clear on the difference between the 211 arm that I just talked about and because community connection is part of 211, but they have a social prescribing model. So I'm going to let Pam clarify all of this for us.
Thank you. So a few things that we get confused about a lot is that 211 is not an organization, that it is a national dialing code. And here's the suite of 3-digit dialing codes that's available across the country today. And in Ontario, calls, including text, chats, and emails, flow across 5 organizations that actually operate as a single contact center. Our community navigators access a database of resources that's managed by an integrated team of data curators. And 211 service is meant to be anonymous. Details for each contact are reported as a single encounter, really meant to be high volume, really connection to services. We do have a BI system that we use for reporting aggregate data on needs and trends and service gaps to communities. So a little bit about Community Connection. So we're a registered charity, and we've been in our community since 1969, had a helpline since then. I think our claim to fame is that, we did information referral before the internet with paper. But today we're a 24/7 inbound and outbound contact center. And our organization is called an information referral organization. We have standards and accreditation that are international through Inform USA, and that's what we use to measure our quality of our programs for information referral. So our main goal is just to help people find and connect with the services they need and to work with partners to advance an integrated service delivery system. And so our work with Simone and her team is really exciting for us in this way. So Community Connection has a license to deliver 211 services in our region. We're one of those 5, and social prescribing is one of our programs.
So you're different from the other 211 hubs. So the 211 hub that we worked with was really inbound calls only. And in your organization, you obviously do the regionals, inbound calls, but you also established an outbound call, which is with a referral from the primary care provider. Right. So like a social prescribing model.
Exactly. Thank you for clarifying that. Yeah. And so our social prescribing model started back in 2015 when the poverty screening tool was created. And our work with the local health links back then was really how can we support our health partners in our community? And I could reference specific physicians that are today where we are. So far, we've received over 11,000 referrals, and we've learned a lot because we didn't know what we're getting into. this is a little visual of kind of our process as it emerged over time, where we were making an outbound call and really just performing what we did through an inbound call. We eventually created an outbound call report and sent that back to the referring clinician. All of this was done by fax. And our work here was really based on our quality indicators as an information referral organization. We didn't even have a clue about the work that we've learned about since what Simone and her team have really helped us understand. But we're built our system on the legacy infrastructure of 211. So it gives us great reach and good strength. And then our navigators are skilled in the complexity of human services and those essential needs. And a lot of our callers are people struggling in poverty and at risk of homelessness. So really focused on a different area of acuity, but everything's interconnected, as we know. So as a result of this work, we've developed a special, unique, scalable longitudinal client database, because 211's database is anonymous. Ours now is longitudinal, and we can now support callers that are repeat callers with helping them not to have to repeat their story. And it's also, we're also now a licensed for the Ocean provider network. And a digital integration with Ocean enables a bidirectional data sharing between the EMR to submit referrals and receive outcome reports back to a patient's chart. And that's the direct result of a couple of physicians in the South Georgian Bay Family Health Team.
This is really important. Yeah.
The portal, on the Ocean toolbar, you can go in and make a referral to 211 right through there and get that outcome report back. And we can also use the Ocean portal to send a referral for those that don't have an EMR. So our current program is light touch navigation. It doesn't have an evaluation component for the clients or the patients. And our partnership with ARC, we really are looking forward to a number of things. More, training on providing holistic services, our communication approach and promoting engagement, our guides and tools for the fidelity that we're missing, and then the randomized trial with the brain-heart interconnected conditions. And Simone, I don't know if there's other parts you'd like to add into that.
No, I think it's really bridging our strengths, right? So the platform that you have, the experience with the experience that we have with the holistic approach and the evaluation, and we're really hoping to be able to establish something that is scalable. That's our intent. Thank you so much, everyone, for listening to us. And we've got 13 minutes for questions. So I think somebody has been collating the questions, so I'm going to stop sharing. And does somebody have a list of things we can talk about?
Yes, Simone, I have some questions from the chat, and I'm adding as they are.
Okay, tell me.
But I can share some of the questions that our listeners had today. So I'll start with those that were around navigation. So the first question is for Nathalie. What's your background? Are navigators needed to have a professional background? So if you want to answer that.
So at the time of the ARC study, I had a Bachelor of Science degree. So that was my background. Following the study, I returned to school and I now have a nursing degree and I'm a registered nurse, but I didn't have that at the time of the study. I got additional training from Doreen and from other people involved in the ARC study. A lot of training surrounding motivational interviewing, how to interact with clients, different needs and things like that.
So that's an important point, because the navigator is a lay navigator. They're not a nurse. I mean, now congratulations, you're a nurse, and you had a bachelor's degree, but you were not a clinician, a nurse, a social worker. It's a lay navigator, and their main skills is interpersonal skills. So that's important. That distinguishes them from the navigators that we're used to seeing in primary care.
Okay, thank you. So related to that, we have two more questions from our listeners. And one is like, So for the emotional support, what kind of training was given to the navigators? And there's another member in the audience who has asked, I work with adults with development disabilities and dual diagnosis. How well the navigators are prepared to support clients like me? So basically around the training for emotional support and training to support people who are facing disabilities and dual diagnosis challenge.
Well, for emotional support, a lot of it, I was provided a lot of training surrounding motivational interviewing. We also did some like role play case studies where someone pretended to be a patient and I was the patient navigator. So we kind of had like a little case study like that. I'm sorry, what was the second part of the question?
People with disabilities, like physical disabilities.
We did not receive a whole lot of training surrounding that piece. That is something that could be potentially explored further, I believe.
So yeah, so it's, you know, it's important. A person can't be trained in everything. So one of the things that the navigator was trained is their scope of practice. What are their boundaries? And for emotional support, it was a lot of active listening. It was a lot of empathy. So that's the kind of training that they got. They're not mental health workers. They were not providing mental health support. They were providing emotional support, just like a friend would. You know, when I describe the navigator to people, I often say it's like the well-informed daughter. That's what that person is. Somebody you can trust, somebody who's going to listen to you, who's going to be give empathy and support you. And they did not have training on, you know, specific populations, but they were clear on if something was outside their scope of competency, like especially around mental health, and there was some concern, and in fact, that's happened a couple of times, we would call the provider, the primary care provider, right away. We would send a fax, we would pick up the phone, and we would talk to somebody at the practice, because if there was something that they were not equipped to deal with, and again, they're not clinicians. They're not meant to provide that kind of service, but they're linked to the clinical group that can help support the patient. And the other thing that we didn't mention is part of the training. So they have their upfront training, and then there's ongoing mentorship and emotional support for the navigator. Because I've got to tell you, I read some of the cases, so they were charting, and I was choked up and upset. And, you know, when you were talking about being discouraged, you so want to help these people, and sometimes there's only, you know, so much you can do, and some things are, you know, some of the challenges they face are not in your hands to fix, and that can be difficult. So they had weekly debriefing sessions more often if they needed it. So I think that's a very important aspect of the navigator role and support.
Thank you, Simone. And we had another question if we had Indigenous scholars as well. So I can say that these were not just scholars, because it was a randomized control trial. So the providers actually referred their patients, and we did have Indigenous participants as well.
Yeah.
And sorry, you want to add something, Simone?
No, I was going to say we had too few to be able to draw conclusions. What we could tell was that their experience seemed at least equivalent. So things seemed to have gone similar. Our navigator was not trained in supporting the Indigenous population. And this is where, you know, at the beginning I said there's a lot of programs for specific populations, and sometimes these are needed. And so maybe for Indigenous population, maybe there is, you know, maybe an Indigenous person would be the best navigator, somebody trained in that area. And so these specialized programs might be needed. And the general program that, like what we have, wouldn't preclude a focused program as well. But we didn't have the training other than general cultural humility. That's you know, the respect for others. I think, yeah, that's the general sense of the training.
Okay, thanks, Simone. And in terms of equity, So one of our participants has asked that, do you have any other data besides francophones? So I think partly you have answered, Simone, that we had participants from other communities as well, but their results, we have not shown them separately because they were pretty much same, and the sample size, if we just look at those communities, the sample size, the numbers were too small, and the results was pretty much the same. But I want to add here that we did look at some other parameters in terms of their association with access, but what we have shown today is only those which stand out very significant.
we can probably safely say that there was no inequities. So I can, there wasn't even a trend towards inequity for any particular group. In general, the ARC model provided helped with what we call vertical equity, so gave better support, or was a better fit for more complex patients, socially complex patients. Sometimes it reached statistical significance, and that's what we reported on. So the education, for example, there's also the low income, which we didn't show, but people with low income were more likely to finish the study if they were in the ARC arm, not in the 211. So there was no hint of perpetuating inequities. Some evidence of improving equity, but still limited.
And we have a question coming back to the training. Was there any mental health first aid specific training for the navigators?
If I recall correctly, it was really just to identify risk situations and know how to address it, and so know who to contact, but there was no first aid. But I'm saying that, but yet I know there was a session on mental health, and I apologize, but I can't remember the details. I don't know if Nathalie, you do.
There was no formal training, like I didn't take the mental health first aid course.
Okay.
But there was, like you mentioned, just identifying when it would be like outside of the scope of the navigator, and when to contact
and
the
what to do,
or someone else.
So I have to say that so we didn't run into problems. We ran into issues where we had to bring in somebody to help the patient. So that's normal. We expected that. It happened. Our process worked. We had a process. There was, we didn't have, and not to say that we've covered all the bases, because things could happen, but there was no instance where somebody kind of fell through the cracks. The other thing is, we always made it very clear to the client that the navigator, that they are not a professional, that they are not a social worker, and that their relationship was temporary. They were there to help get them to where they needed to be in terms of accessing resources, but not really beyond that. So it was not going to be like an ongoing social worker relationship.
Okay. And we have another question which asks, is the work of ARC going to be helpful to open the door for the Ministry of Health funding for these types of essential services within primary care?
I hope so. I hope so. And I know there's good intention, actually. I hope that I hope there's some folks from the ministry. I know that they are interested in this. Whether they're able to invest in it, I don't know. I do want to say one thing, though, to people who are attending, because I know that there's people from various backgrounds, and that is that the ARC program is still sort of under research, so it's not publicly available, is what I'm saying. It's definitely ready to be implemented, no question, and we're, but it has not been adopted for implementation anywhere. So you can't right now ask your provider to refer you to, as part of a social prescribing. So I just wanted to make sure that nobody sort of left expecting that they could call and get the navigator. I do hope so. Thank you for that question. And, I know navigation is very important to the ministry. And I know they're actually quite well aware of the need to address the social determinants of health, because probably most of us who are here know that 70%, that's what the studies show, 70% of our health is determined by our social context, 70%. So we really need to pay attention to that.
Thank you, Simone. I think we're coming closer to the end of the session and we don't have I have no more questions from the chat.
I'd like to thank Simone, Pam, Natalie, Karen, Kiran. All of you have given us a great sense of the possibility that this can work.
Yeah, thank you for this opportunity.
Which is wonderful. So I hope we can carry the dialogue further and with the ministry. Thank you again. Thank you very much.
Thank you for this opportunity. Bye-bye.
Bye-bye.